We'll be calling on the next speaker, Dr. Hany Shab, he's a pioneer in third spacing at Space Endoscopy and Bariatric Endoscopy, founder of First Integrated Clinical and Research Center for Intestinal Disorders, director of advanced endoscopy courses and leader in developing tunneling techniques, and expert in post-bariatric complication and stent design. We'll be talking about endoscopic management of post-bariatric complication. Talk is ready now, Dr. Hany Shab.
Yes, so first of all, thank you very much for the kind presentation, Dr. Qahtani. I'm very proud to be in this eminent conference and meeting. So I was asked to talk about the endoscopic management of post-bariatric surgery complications. It's really a very difficult topic. It's one of the topics that I actually have become not very happy to do these last few years. They're very complex cases. And also it's a very, very wide range of complications that we have that endoscopy can really help. And I think endoscopy is the primary way to go in most of these complications. Due to the time restrictions, of course, I won't be going through everything, but I'll be mainly focusing on the leaks, which is the main, most troublesome issue, and some of the outflow obstruction issues. So first of all, the leaks. And I think, yeah, leaks, it's very important for those who are maybe starting in the field of endoscopy to know that it is not just a simple hole that you have to close. It's really a storm. This patient coming in who's already morbidly obese, he has chest problems, he's diabetic, and he has this life-threatening sepsis. So it's really a catastrophe that you're facing. It's not something to take lightly. So our approach, when we started working on this, I think maybe like 12 years ago, is that I think we were one of the first teams that started working with these bariatric specific stents. This is the mega stent from Taiwan. These are really massive stents. We have diameter reaching up to 36 millimeter. They are, have the advantage of being highly flexible, as you see, and really large to reduce the risk of migration. And this is one of the older videos, but I really like it because it shows you many things in bariatric endoscopy. So this is a patient who had Roux-en-Y gastric bypass, presented with sepsis and a leak. He came to us about 2 weeks after the surgery. And here we're at the cardia. And then just after we passed the cardia, first of all, we imagine that this is the lumen or the gastric pouch. And then after closer assessment, we found that the lumen is actually down here. This is the jejunum where we enter now. So we come to appreciate that almost about 50 to 60% of the anastomosis is completely disrupted. So you see here, these are the intact sutures, and all this is the jejunum. So actually, when we find access to going outside into the abdominal cavity, this is something that I'm actually very happy with. We don't actually just pull the endoscope out and then call the surgeon. This is a very good opportunity for me to do some lavage, some cleaning. We do this, we use baskets, we use continuous lavage with saline, sometimes antibiotics to clear the leak cavity or the peritoneal cavity, and then we proceed with doing our procedure. So in this case, due to the very large dehiscence, we decided to do something. We decided to do some approximation first before trying to do anything. So as you can see here, there's just the contrast is going everywhere. There's no like fistula or something. So in this case, we decided just to approximate a little bit the tissues. So we used a Ovesco clip, and this is using the twin grasper. We know very well that any clip you'll put here, it won't hold. We know this very good, but we just wanted some approximation just to reduce the healing time a little bit. So here we applied a Ovesco clip just to approximate. Of course, it's not easy with the fibril tissues, with the fibrotic tissues. And eventually you put one clip, and then we put another clip beside it. We know very well they just hold for maybe a few days and then they fall back. So then we put this large mega stent, and you see the clips here inside. And then we followed this patient after several weeks. So after 8 weeks, we have now this view. The clips, of course, have fell out, but we're starting to have a proper anatomy. So you see here, this is the lumen of the jejunum. But there is still a small tract here, which is becoming now a fistulous tract, but we do have some proper lumen now, which is different than what we had before. Now, when you approach this fistulous tract, now it's different. Now this tract is chronic, it has epithelium, it's epithelialized, So you really have to do something to de-epithelialize this tract to help the healing. So this is why now we decided to do some de-epithelialization using APC. So we try to do some ablation of the edges of the whole tract, right up to the edge. So you're trying to create a new raw surface area. And then we put another one of these large megastents for another 6 weeks. And then when we look now, we have this lovely view. It's completely healed. And it shows you that, yeah, with persistence and with really approaching the patient differently according to the timing you enter, his general condition, if it's chronic or not, you can achieve very good results. So this is our study that we did on the use of these very large megastents. I think it's a very important study that showed us many things. One of the first things that, yes, we know it gave us, we reached the result of about 82% success rate, but the more important thing is that we showed that in one attempt you reach only 50% success, but if you do persist more, try either by putting further stents, other endoscopic modalities, another 32% will actually reach leak closure. And this was a very important message, not just to us, but to surgeons who very frequently, when you tell them, okay, we put a stent, the patient still has a leak, he says, okay, then endoscopy failed, send me the patient for surgery. But this is a very important message. You have to be patient. As long as the patient is stable and he's doing well, then you continue with the endoscopic procedures. We also clearly demonstrated that these stents are really, really very traumatic. Intolerance is very high, 10%, they just can't stand them, we have to remove them. And they are morbid. We had bleeding, we had perforations with these. Fortunately, no stent-induced mortality, but they are morbid, these very large stents. And yes, they have a lower migration rate than standard stents, and you use less stents per patient. But yeah, the intolerance, the perforation, the strictures really make them a bit problematic. One of the very important findings, I think, that we found in this is that we found that the only factor related to having a major complication was if the patient had an open surgery before, not laparoscopic. And we kept thinking, why is that? Why would a patient with open different from a laparoscopic patient? And we came to this conclusion, which really makes sense for me, that patients with open surgery, they have these massive adhesions. So they're sticking, for example, the jejunal loop just after the anastomosis to the abdominal wall. So this jejunal loop where you have the stent stuck inside is not flexible, it's not pliable. So as you can see this example, this is the stent with its sharp edges coming down here, and this is the jejunal loop. If it's fixed with adhesions, with every push down with the stent, it won't be pliable and go with it. So the stent will really tear through it easily, causing bleeding, causing a perforation. So after this study, we reached the conclusion that if you have a patient with an open surgery, we do not use stents, definitely not the large mega stents. We did work on modifying a stent. This is not the stent that we're working with nowadays. It has much less sharp edges and it's much more flexible. We hope that they do give better results. After that, endoscopic internal drainage has become my favorite approach, which is basically like what you do when you have a pancreatic pseudocyst. So you have a leak like this one. Here in a Roux-en-Y gastric bypass, you go usually with a duodenoscope, side viewing endoscope. You pass a wire through the tract to reach the leak cavity. You put your double pigtails, and usually in a few weeks' time, when you pull it out, things look better. And of course, these have a huge advantage. You don't have the massive pain of the stents. You don't have the major complications. And many of the experts worldwide say, okay, now you shouldn't use stents anymore. You should always use endoscopic internal drainage. But I'm really against this one-for-all approach because you will see some examples. For example, this is an example of a patient also with a leak post-gastric bypass. Here, this is the view in the lumen. Actually, this is the lumen, which is apparently very stenosed, and this is the leak. Now, we know from the basic surgical principles, if you have a distal obstruction to a fistula, it is one of the major causes that will stop the healing. So no matter how many pigtails you put in this hole, as long as the pressure is high below, then it will never heal. So in this case, you can't just put an endoscopic internal drain. In this case, we put a stent. And we left the stent for several weeks, and eventually, it did heal the stricture, and at the same time, it healed the fistula. So you really have to individualize this approach. this is an example of a patient who actually had an esophagogastrostomy, who had a major leak. And as usual, we're really happy to go through the leak with the endoscope. So yeah, here we're out of the leak. And actually the gastric sleeve, you can see it here on the left side. And this is the abdominal cavity. So yeah, this is the sleeve. So what we do now, previously we had this conception that to do endoscopic internal drainage, you must have a contained leak cavity where you can put the pigtails. But this case demonstrates that this is not a prerequisite, actually. In this case, first we tried to put a stent. Because the lumen was very wide, we put a partially covered stent, but even when it stayed in place, the contrast came out and came through the fistula again, so we knew this is not a proper solution in this case. So we pulled out the stent, we went into the leak cavity, we put the pigtails. You can put as many pigtails as you want in the cavity. So this is the image with the pigtails in place. The patient had a feeding jejunostomy, which is something very important. So after several weeks, it's fine, but there's a very, very little streak of a leak that's remaining here. So we just extend the duration. We exchange the pigtails and put the patient on oral feeding. Now he can feed. After 4 weeks, it's okay. And finally, you reach a situation where the leak has completely healed. I'm sorry, I'm just running quickly due to the time. And you have the healing of the leak with endoscopic internal drainage. So yeah, this was in a review that in 2018. So yes, I changed my mind about that a contained leak cavity should be present when you do endoscopic internal drainage, but you can see that there are advantages and disadvantages of each procedure, and you really have to be flexible in using each of one. Endovacuum therapy, I won't talk about it much because I really don't like it. I know this is against many of the expert views right now, and it could be due to the type of cases that I see. I know endovacuum therapy is excellent in patients who have mediastinal leaks, because if you have, in the thorax, you have the negative pressure, so if you put a pigtail, it won't help, it won't drain any leak cavity, so it's excellent in these positions, in these situations. But there are problems with this, and I think, at least for my patients in my country, it's not very useful or suitable or acceptable. Patients need several sessions. They say 4 to 5. I say in many patients like 6 or 7 sessions. You have to have the patient on continuous suction. If you want to send him home, you have to find him this portable suction, and it gets blocked every day, and it's really not helpful. The patient should be on NJ feeding, but in certain situations, it does help. I'm not an expert on it. Some people do it more than me, but I'm not really a big fan of it. Vascular plugs have been a gadget. Many people have vouched for it. I think there is a huge publication bias favoring it. I don't think they're that successful. This is one case that we did that was successful in a chronic leak. So you see this is the gastric sleeve. This is a complex leak outside the stomach. So we used this catheter to put the vascular plug. So yeah, this is the vascular plug in place, and below here, this is the lumen. And of course, it's not a one-time fix. It takes time, okay? Because it takes time for the tissues to grow on this mesh. So in 1 week, you see here that there's still an area around it that's still leaking. These patients do need a feeding jejunostomy. But at week 5, we find that, yes, things that have actually closed. And you can see here that it successfully closed completely, but I would say the success rate with these plugs is about maybe 30 to 40%, so don't be really swayed by the publications of a nice small case series. This is one study that I was glad to join. It showed something very important, that the success rate in healing a fistula by endoscopic procedures usually plateaus after the 4th or 5th technique. So yes, I do say persist with the patient, but really after the 3rd or 4th trial of endoscopy, you have to be frank with the patient, you have to involve the surgeon, you have to consider that you probably won't have much success doing any further things. Now for leaks, there is the fine print. I have to say this because many people come to conferences and they see these nice endoscopic pictures of before and after, and leaks have healed and so on. But this is not the reality. In the reality, this is the type of patient that you have when you first see, with all his comorbidities and difficult endoscopies, difficult position to work. And the patient, there is a chance that you will lose the patient. It's really a very stressful situation. When you have this patient, you know that for the coming 6-8 weeks at least, you will be woke up in the middle of the night. Even when you send these patients home with this massive stent inside, you just don't tell him, come to the ER. I give him my phone number if you have something, because he can have a perforation, he can have major bleeding. So you will be with this patient for several weeks. Not only the patient, we have the patient family. Okay, they're not always as friendly. I'm talking to you from our experience in my country at least. No matter how much you explain to them that we're doing something that cannot work, after several trials and weeks, they become frustrated, and it's something that you have to handle. It all adds to the stress you have. Medical legalities are immense in this, especially if you're in a situation or in a country where there's no much real protection of you. You have to be very careful, and no matter how much you do consents, sometimes things can go wrong, and sometimes you can fall into legal issues, so you have to have this in mind. The financial issues are a big problem. Almost all these patients, they are self-funded. So many of them, they don't have the money to pay for the complication. They don't have the money to pay for the stent. They already paid everything for the surgery. So you have to have this in mind, who will pay for this? So it's a huge thing you have to keep in mind. It's not all just a glory and putting a stent and going away. So just keep this in mind. Rapidly, okay, strictures, kinks, and twists, they are another problem. The main thing is, of course, the balloon dilatation. This is the standard, and I think this will be addressed in other sessions more clearly. I just want to show something that may be a little bit different than the standard balloon dilatations, which is doing the tunnel stricturotomy. And this I find very useful because these are usually very hard to treat strictures. This is a nice video I borrowed from my friend Diogo in Brazil. I think they're the ones who started this technique. So basically, you do, as if you're doing a G-poem, you do a submucosal tunnel, and the aim is that you want to reach this area and you want to cut the muscle or even through the whole thickness. So yeah, once you expose this and you're going just beside the suture line, you then remove the muscle and then you close the entry site, either with suturing or with basic clips. This is what we do. We don't have available the clips. So this is an example of a patient with a sleeve gastrectomy who had a very tight stricture and kink. So here we start just about 3 centimeters above the incisura. We do this bleb like you do a G-poem or a poem, and then you do the submucosal tunnel. Of course, it's much difficult than a G-poem. You have the fibrosis of the suture line just beside you. So the suture line is just on my right side, and I'm tunneling just beside it. And you have the tight angulation also. So yeah, once you do the tunnel, you start dissecting through the muscle. You see the intense fibrosis now because of the suturing. Now when I do this, I do it, initially we try to be careful not to pierce the serosa. You can see the serosa here, but now I think it really doesn't make a difference as long as you actually close your entry site very well. So here we're doing the stricturotomy. You're cutting the muscle with the fibrosis. So you see here now we're full thickness. Of course, this is done using CO2. And after a while, you can see the liver edge outside. This is some omental fat. There is the liver edge. So we're happy we had now a full thickness here, and you finish the procedure by closing in, and here we did with clips. We closed the whole entry site. The patient does well, and when we see this patient, just after a few weeks, you find now that the passage is now widely open, and the clips are in place. So I think it's a very useful technique. This is another patient who had a sleeve gastrectomy, who had persistent vomiting and hypokalemia. Gastric scintigraphy revealed markedly delayed emptying, and you can see here why. She has severe pylorospasm. And the antrum is actually very, very tight. So you see we can't pass through the pylorus due to the severe pylorospasm. So what we did here is we did a G-poem. So the GPOM with the aim to open the pyloric ring. So we do about 5 centimeters more proximally, and of course it's a bit tight. You do the injection, and you start the tunneling. Here, of course, the mucosa is on the right, the muscle is on the left. Here we're in the tunnel. Here we use this insulated tip knife to cut the pyloric ring, which is this rim on the left. And after we cut it completely, we go out to have a look. And now you can see that we enter through the pylorus easily into the duodenum. It's an easy passage. And this patient had a remarkable improvement of her symptoms. See, this is the tunnel, and this is the entry into the through the pylorus, which is now open and passes the endoscope easily. So in conclusion, my take-home message is, for leaks, you really have to be patient. It is the most important virtue.